Hi everybody. So today we're going to do an interview. This is Kelli Slater, and she happens to be my sister-in-law, but she's an occupational therapist. So I wanted to give you a little bit of insight on what an occupational therapist does. I wanted Kelli to explain what her daily job was. A lot of you might be interested in going into occupational therapy, so I wanted to allow Kelli to talk about what she does on a daily basis.
Okay, so I work at an inpatient rehab hospital in St. Pete, Florida. But the nice thing about occupational therapy is it can go into a very wide variety of settings. So for instance, if somebody's more interested in working with kids, more of the pediatric area, they can work in schools, they can work in hospitals specifically for kids. I prefer the adult, older, geriatric population, so I like to work in the hospital setting. But there's also skilled nursing facilities, outpatient clinics. So
What's a skilled nursing facility?
So a skilled nursing facility is a slower paced type of rehab unit. Some patients actually do live there, so they'll get therapy, but they also live there as well. And that's where they'll stay when they pass on. But sometimes people will use it as a stepping stone to...
A rehab area?
Yes,
okay.
They can. A stepping stone for rehab where it moves much slower, so it gives them a little bit more time to heal. The therapy is not as intense, so you stay there for a little bit longer with the hopes of then still being able to go back home. Whereas where I work, our patients stay with us for about 2 weeks. They get therapy 3 hours a day that's split between my discipline, physical therapy, and then speech therapy if they need it. And our ultimate goal is to get them to go home. So they get admitted into the hospital for whatever reason. They come to us for about 2 weeks, and then we're trying to get them home. So it's really aggressive. They do 3 hours of therapy a day. But that's our ultimate goal, is to get them better, or at least independent enough to where they can go home.
What are some situations of patients that you've had? Why are they getting the occupational therapy in the first place?
So with working in the hospital, my hospital specifically is a trauma hospital. So we kind of get all walks of life. So we get, people in general who just trip and fall and they break a bone, or a little bit more trauma. So, unfortunately, bad car accidents, some gunshot wounds, or just like really fluke accidents where they might now have damage to their spinal cord, so they can't move either both of their arms and their legs, or maybe just their legs. So it's something new and different every day. So you can think anything like that, strokes, traumatic brain injuries, it all is going to affect the way your body moves, how your arms move, how your legs move, how you talk. And so occupational therapy, the main focus of that is to really promote what we call activities of daily living. So think about what you do when you wake up in the morning. You get out of bed, you go to the bathroom, you maybe brush your teeth, take a shower, get dressed, cook yourself breakfast. All of those things are what we call activities of daily living, and so that's what I focus on. So if one of your arms isn't working, I need to figure out how to make you independent by still getting yourself dressed so that you can still go to the bathroom by yourself.
With one arm.
With one arm. And sometimes it's not that black and white. Sometimes you only have one arm that works, but you can't speak back to me. So something happened in your accident, or something affected you by a stroke or something like that, where your communication isn't how you and I are talking right now. You can maybe understand me, and you think that you're talking back to me, but words are coming out very jumbled, or they don't make sense. And so it can be a lot of different things combined together to kind of get you back to being independent.
So if you had a patient like that was also having maybe verbal communication challenges, are there other people in with your therapy session at the same time to assist you, or do you have to handle it?
Most of the time it's just one-on-one, where it's just me and the patient, and I focus solely on what my discipline is. But that's kind of the beauty of rehab in general, is that, with physical therapy, I have to be able to transfer them and move them from one place to another. As well as with speech therapy, I need to learn from my coworkers how I can try to effectively communicate with a patient when it is my one-on-one session. Now, if the patient is really involved, then we can work together. So I can have a session working on what I need to work on, but then the speech therapist is kind of also helping me while they help the patient, so that we can try to figure out a way to best effectively communicate.
Awesome. Okay. And was this always something you wanted to do? What was your path to get here to where you are?
So I actually feel like it found me a little bit. I really wanted to be a physical therapist. I wanted to do the athletic training route, and I wanted to be one of those people that was on the sidelines with athletes. This is now like completely opposite of what I thought I wanted to do. So what really started to kind of change my mind a little bit, truthfully, is when I got to college. You do have to take a few math courses, physics in particular. Physics 1, okay, but you do have to take Physics 2 to become a physical therapist, and that just wasn't for me. So I started to find and kind of look at different alternatives at that point because I was already so far in. But no matter what school, what grad school you want to go to for either physical or occupational therapy, you have to have observation hours. So I found local therapists in the area, and I thought, okay, well, I've never heard of OT, so I'm going to go and just kind of observe. And that's when I fell in love. I think OT is, still get to do a little bit of the physical therapy part where I can still help somebody learn how to walk and stand up, but I also get to, kind of delve into the cognition part of things of what speech therapy does. So I feel like OT is just kind of a nice blend of doing all three. Excuse me, but I feel as though what I do in my mind is a little bit more rewarding because I feel as though people take, getting dressed and going to the bathroom for granted. It's something that they've done all your life. You don't really have to think about it anymore. And so when you're not able to do those things for yourself, it can be very humbling because, you don't really want to have to rely on somebody to help you go to the bathroom or things like that.
Or to get dressed by yourself.
Exactly. So I say it kind of found me just because of my learning style. I knew that the path of getting to PT just I wasn't going to be successful at it, but I still feel as though I'm very much a part of doing what I thought I was going to do just a little bit differently.
Do you find that a lot of people confuse physical therapy with occupational therapy, and how do you describe the difference between the two?
100%. So a lot of times when people say, oh, what do you do? I'm like, oh, I'm an occupational therapist. They'll be like, oh. And you can just tell right away they have like no idea what we do. So a lot of the times I'll say, oh, we work really closely with physical therapy. And usually the difference between any setting, whether it's like a hospital or a school system or whatever, we kind of cut the body in half. So like physical therapy will work on the lower half, so the legs, your knees, your feet. So they work on, your posture, your balance, walking, obviously. And then occupational therapy will work from like the waist up, essentially. So we kind of still work on like trunk control, right? Because when you're getting dressed or anything, when you're sitting up straight, you can't really get dressed when you're sitting like this, right? So we still work on trunk control, and then we're really involved in like the arms, getting your fingers to work, your hands and elbows and everything, to move together.
Is it both fine motor skills as well as gross motor skills,
Yes.
combined? Okay.
Yes, yeah. So the big difference between the two really is PT helps you walk, essentially, and then OT kind of does the more fine motor things. But when you kind of break it down into the setting that I specifically work in, I help you get dressed, go to the bathroom, take a shower, learn how to recook. Exactly, life skills, yes. Mm-hmm.
Okay. Educationally, what kind of a path does an occupational therapist typically have to go? Like, what route are they going to go in?
Okay, so you do for your 4 years of college.
So like a bachelor's degree.
Correct, a bachelor's degree. You have to have a master's degree to be an occupational therapist. I have heard that they are changing things. To be a physical therapist, you actually have to have a doctorate.
A physical therapist.
Correct, yes, sorry. But with OT, they're now changing it to kind of mirror what physical therapy is doing. So I think in a few years, they are making it also become
like
a doctorate degree. So it's, I only did 2 years of grad school, but it would be 3 years of grad school continued on to get your doctorate.
What did your bachelor's have to be in? Is there a specific focus? Do you have to go like through a medical route?
Yeah, interestingly enough, not really. As long as you just kind of meet the requirements or the prerequisites for grad school. So for instance, my background was exercise science. I wanted to learn how exercise affects people who have, just different, not even disabilities, but we can call them like comorbidities. So like if somebody has, really bad COPD, if they have bad asthma, or they were a really bad smoker back when they were younger and now they've quit, I wanted to learn how exercise kind of affected their body years after that. So I did exercise science, but there was one, I had a classmate, actually, her background was theater. She majored in theater, but she had prerequisites to meet the requirements. So you can really do anything. And I think that is very helpful because with OT you have to be able to kind of think outside of the box sometimes. And so not always coming from like a health or a medical or an exercise background can sometimes be very beneficial.
How did your friend, using her theater background, how did it help her?
So she was very good at the artsy type of stuff, and she knew she wanted to work with kids, so she went the pediatric route. So for her it was great, but she was also very into like dance and singing, and so a lot of times with the people that can't communicate very effectively, there is something to be said about music therapy, and so sometimes speech therapists will actually have patients try to sing before they talk because of the melody. And so so with communication it really worked for her because one, she could actually sing, and two, she was really very dramatic, and so sometimes big movements can really stimulate the brain. So with kids, she was great, whereas with me, with a kid, I was like, okay, what kind of games do you like to play? You know, so it's just very different when you figure out what your interests are the further you go in.
What is the oldest patient you've had?
I worked with a patient who was 102.
What?
Yeah, he had his birthday when he was with us, so 102. And it's amazing. You know, some older people, I swear sometimes they come in and I think they're in better shape than I am. You know, they'll always say, don't stop moving. So just, you know, don't get lazy. But they can teach you a lot. Yeah, exactly.
And what's the youngest patient you've worked with?
So with my hospital, we can't take anybody younger than 16. Because we're not a pediatric hospital, so we have had a few 16-year-olds that have come in, which is a nice change. You know, it's a little bit of breath of fresh air from working with people who are in their 60s and 70s a lot. So anywhere from like 16 to 100, you get all walks of life.
Okay, so walk me through your day.
Okay.
You get to work. Tell me from beginning to end, what is it that you have to do?
Okay, so I get to work, and how I work, we all have a schedule, so I know exactly what patients I'm going to see. I usually see them for either an hour or 30 minutes at a time, depending on what their schedule is.
Typically, how many patients do you see a day?
So I'll typically see 5 to 6 patients a day. Okay. And then the morning part is really what we call ADL, so that activities of daily living. It's very ADL heavy, where we're trying to just get the patients dressed or showered and ready for the day, and we're trying to make it as therapeutic as possible.
So you're assisting them doing their daily activities,
yes,
or ADL, activities of daily living.
Yes.
But you're getting them to try to
do it themselves.
Okay, so
I'm just
building that independence on
yes.
that. Okay.
So I kind of facilitate that. So I give them cues, or there's, you know, certain techniques, or there's, you know, certain pieces of adaptive equipment that we'll educate them on. And repetition is a big thing. So the more you do it, you know, the more they get used to it, especially if there's some cognitive deficits going on. But it's just like with anything, you know, if somebody gives you a tool and they're like, okay, you're going to need to use this for the next 6 months, the more you practice with it, the better off you're going to get.
Like Zoom. Now we're getting really
good
at
exactly. Zoom. Yes. So that's kind of my morning. And then my afternoon, we kind of will work on more of the fine motor and the gross motor things. So
do you see the same patient more than once throughout the day?
Yes. So my 5 to 6 patients, I'll see them in the morning,
usually,
and then sometimes
ADLs,
I'll see them again in the afternoon.
And then you do the fine motor in the afternoons.
Yes. So it really allows us to kind of create a very close relationship, because you're working with them, you know, Monday through Friday for at least an hour and a half a day sometimes. And so you really get to know them. You get to know how they learn, what makes them mad, what makes them happy, what makes them sad, and how you need to kind of alter your therapy session to where they're going to be the most successful.
You said when they get mad, have you found patients that have gone angry towards you because you're pushing them perhaps to their limits?
Yeah, so sometimes it's hard to kind of hold back when you can really see the potential that a patient has to kind of get better. But I think sometimes I forget how challenging it can be to relearn how to do something that does come so easy to all of us. So sometimes, and they'll tell you if they're able to, like, you need to stop, I need a minute. And that's great. Like, we want them to tell us that, because I don't know. You know, everybody's tipping point is different. And some people need the push because maybe they're not trying as hard as they could. And then other ones really are trying as hard as they possibly can. and you just want them to do it so bad that they just can't right then, and they just need a break.
Do you find that some of your own personality traits come out into you as being an occupational therapist that either help you being an occupational therapist or sometimes maybe like make it more of a challenge?
I feel as though I talk to my patients like I talk to my family members or my friends. And for the most part, it pays off because I think sometimes people want the mental distraction of where they are and what has actually happened to them. And so I think they want to be treated as a person and not always just as a patient. Yeah. However, sometimes you get so comfortable with a patient that you feel like you go to say something and you're like, oh, I'm at work. We still need to keep this professional. We can't, whatever the topic is, and patients, the ones that have been there for so long, they know so much about you, because they don't have anybody else to talk to, especially with the pandemic. Their loved ones weren't allowed to come in to see them, so you were really all they had, so you really wanted to create that rapport with them, and so, they know your family's names, and they know how many dogs you have, and if you're married and have kids, and because you need to find other things to talk about instead of just the task all the time. So there is that fine line of you want them to feel like you are their friend, because you are, but then you also need to remember that you're there to get a job done because they want to go home. Yeah.
Right. Is there ever like a block of time during the day where you all are, maybe as a physical therapist, the occupational therapist, maybe a speech and language pathologist, are able to meet together to discuss cases?
Yes. So every morning we have a quick huddle and we'll go like patient by patient, and that's when somebody will say, hey, I'm having a really hard time with Mr. So-and-so. Does anybody have any suggestions of how to help him reach this point? And maybe the speech therapist will speak up and say, sometimes if I say it this way, it will kind of change the way the patient thinks about it. So that is very helpful. You really have to rely on your other coworkers of other disciplines because you are working as a whole. You're sharing that patient, and so if somebody's doing something that's very successful, you want that patient to carry that over. So I want to do what they're doing to try to get my therapy to go the same way. So you have to work as a team. It's never just, this is my patient and this is my session. I am constantly thinking about feedback that a physical therapist or a speech therapist is giving me on how to really help this patient succeed. And then we also have times, we meet once a week with the doctors as well.
The physicians that are there, like, for their actual medical...
Correct.
Okay.
Yep. We meet once a week with them, and we go over kind of, how the patient is doing, what are we working on right now, how are they doing right now, and then how much longer do we think that they need to be here, are we having some struggles. So sometimes patients that are with us, just because they're in therapy, they're not always willing to do it. So you really have to kind of... encourage them to, if you want to go home, you have to do this, but sometimes, people just don't want to, because again, they're a person first and then a patient second, and so sometimes they're just not in the mood, or, they can be really nasty. It's not like everybody up there, it's not like rainbows and flowers every day, they can be mean, and they don't want to do it, and sometimes they're mean because things happen in the traumatic injury that they had that unfortunately changes the way the connections are in the brain. So you could have had this really sweet older lady before, and then she had whatever accident she had, and now something kind of switched in the way she's thinking, and she can be really nasty. And so it's just kind of learning how to make her kind of recognize that that's not okay, not socially acceptable, and then trying to kind of still work your therapy into that.
Have you ever been hit?
I have, yes. Yeah.
What were some of the...
Sometimes I feel as though patients just don't really know what they're doing when it's happening. But anytime you work anywhere, you're always going to go through some type of orientation of like what to do, of how to defend yourself. But anytime, you get whacked, thankfully for me it hasn't ever been hard, or, I've never had to go to employee health or anything like that. But usually we stop therapy at that point because they're just so agitated. Trying to calm them down is just not going to work. It's going to make them even more agitated. So There are certain restraints in the hospital if we have to use them, if they're really becoming, very belligerent and just unsafe to themselves, not just to us,
Right.
but, if there's a potential for them to hurt themselves, then, there are some other repercussions that we do just to keep everyone safe. But yeah, it can happen. Spitting, biting, kicking. Yeah.
Got it.
Yeah.
If you were not, obviously you said you wanted to go the route of physical therapy or athletic training.
Yes.
Now that you've been an occupational therapist, do you ever see yourself going perhaps into a different career or a different route from here on out?
I don't think so. I think because my job allows me to do, there's so much opportunity with it. And so, what I mean by that is if there's ever a day where I feel like, I just don't really want to work in a hospital anymore, or I want a change, I can go and try to find like an outpatient clinic. And yes, I'm an occupational therapist, but depending on where you work, you do so many different things. So I would honestly feel like I was kind of starting my career all over again because of the certain things that we would focus on.
Okay.
Yeah, so like those with kids that are working with kids in pediatric places, their main focus is really getting the kids to meet their milestones. So, by age 4, a kid is supposed to be doing XYZ, and by 5, there's, I think by like 8, kids should be able to tie their own shoes and things like that. So they're working on much different things than what I'm working on. And so it's just like a whole different way of doing your same job, but we are still an occupational therapist. So I think because there's so many options for me, I would still stay in that route.
Do they have, I know everyone, like you're an occupational therapist, but do they have like specialization or names or titles? No.
Not usually. Now you can get certain like certifications to kind of go behind your name. So like for instance, there's like a certified hand therapist. So you would go to an outpatient clinic and this person specifically has done extra schooling or extra, not really
Specifically
schooling,
just for the hands.
just for the hand. And so they can make you all types of crazy splints and things like that. And they're usually found in outpatient clinics with like orthopedists and things like that. You can get a specialization in certain like neuro like diagnoses and things. The thing about our profession is every 2 years you have to renew your license, and by renewing your license you have to get a certain number of continuing ed
like a
credits.
CEU.
Yes, exactly. And a certain number of them have to be live. So like I have to go and sit in on a seminar or something to learn.
Like a course.
Yes, exactly. And sometimes they're a day or they're a weekend. And then other ones can be online. But it's a really good way to kind of stay up on what is changing in medicine because it's changing every single day, especially now with the pandemic. All kinds of crazy precautions and things are coming out. And I have to be up on that just as much as the next person. So that is one thing that I really like because it forces me to kind of stay up to date on what's going on and just like modern medicine in general.
Okay, and you brought up the pandemic. Has the pandemic changed how you have to do your job, or obviously there's more precautions you need
Sure.
to take?
Yeah.
How has it changed your daily life
So-
going to work?
Yeah, I have been very grateful that it actually hasn't changed my daily routine because I work in a hospital, pandemic or no pandemic, it never closes. And so I still got up and went to work at the same time that I did before the pandemic. Like you were saying, a lot more precautions, so I have to wear a lot more of protective pieces. So we have to wear a face mask and we have to wear a face shield, and depending on if our patient had COVID or actively has it, we would have to put on other, PPE, personal protective equipment, to kind of keep us safe because...
In addition to the mask and the shield, what would be more PPE?
Yeah, so there's a certain mask, I'm sure everyone's heard of it, of an N95.
N95,
Yes,
okay.
so you would wear your N95 first, and then you would put your mask on over that, and then your shield.
So 3 different things.
And then you would put on a bouffant, which is like the hair piece. So that would go on next. And then there's a certain gown that you would wear. You would put
On top
over
of
your scrubs. Yep.
Okay.
And then you would also put on basically like surgical booties on your feet. You didn't want really any part of your clothes or your skin essentially to be exposed.
Got it. Okay. With the pandemic, not I don't want to say parents, but family members not being allowed to come into the hospital, and that patient might be alone. Has any of that changed, your therapy with the patients?
Yeah, so actually in the beginning, a lot of our therapy was helping the patients figure out Zoom or Facebook. You can, FaceTime through Facebook if the patients didn't have an iPhone, or using the iPhone to learn how to FaceTime. A lot of the older generation, they don't really know how to do that. And so you had to get really creative, because for them, it's very therapeutic, and you have to think about how much fine motor goes into actually using your phone. And if you only have one hand, or let's say some of your fingers got amputated, you have to figure out how that patient is going to be able to use their phone. So is it going to be mostly like voice activated? And can they speak clearly and loudly enough to get Siri to understand what they want? So yeah, it was challenging for them and for us, but I would say that's probably been the biggest change.
That's so great that they had therapists like you that could teach them that, because some older generation, they might be home alone trying to figure out Zoom, and you're only looking at the top half of their face, and they didn't figure out how to lower the camera, but they had you to help them. That's fantastic.
Yeah.
So you brought some of your tools.
I have some tools here. So a lot of times, depending on what has happened, we will use some pieces of adaptive equipment. So for instance, we'll take something like really basic. So somebody's come in and they, fell and they broke their hip. Well, sometimes depending on how the surgeon goes in to replace the hip, you have certain precautions. And so one of the precautions is you can't bend over, right? You can't bend past 90 degrees. So if you're sitting in a chair, right, you can't go forward. You can come up, but you can't go forward.
You can lift your legs, but you can't pull your trunk down. Okay.
Yes.
Okay.
So we will use some pieces of adaptive equipment to help them kind of get their lower body dressed. And so some other diagnoses that would happen where you can't really bend over is, like, let's say you had some type of spinal injury, or you broke your back or something like that. You can't bend forward because you don't want your spine to stretch out. You want everything to heal. So when you bend, your spine elongates. It gets longer because you're going forward more, and you don't want to do any damage to that. So there's all kinds of tricks and tools that we can use, but these are some of the basic ones. So this is a reacher that is probably really common.
It's like what they use in Disney to pick up
the
garbage.
Trash. Yes. And a lot of times that is what patients will tell me that they use it for. Oh, if something falls, I go to grab this. A lot of times they don't know that they can use it to get themselves dressed. So I can show you that if you want.
Sure.
Okay. Alright, so I'm just going to put this on over my leggings, but here's like a pair of shorts, right? And so what we would have them do, so I'm just going to pretend like I don't have one arm, just so everyone can kind of really see how to do it. So I'm going to sit on this arm, okay? So I'm going to use my left hand, and all I'm basically going to do is pull up one side of the leg here. Now I do this all the time, so I know I make it look kind of easy, but and then I'm going to grab my pants here, bring it down. So watch my body, right? I'm not leaning forward, but I'm essentially like fishing for my foot. Okay, so I'm going to pull it up to my knee, because you can touch your knees without bending forward. So once you get it on one side, you're going to find your other pant leg and shake it around a little bit so that you know exactly what you're aiming for. And then you use your reacher. You got to use what you have sometimes. You use your reacher, bring it back down. You're going back fishing for your foot. And then you just kind of work it in there. So, with somebody who had like a hip replacement, with one of their legs, it's going to be a little trickier to like pick up their leg or to like kick it out. But usually with time they can do it. This can get a lot more involved with somebody who has had like a stroke or something and only one side of their body works. So then you know, other things come into play. So at this point, we would then stand up and then we would pull our pants up. So obviously it's much easier if you use something that's looser, which is what we always recommend when patients are still learning how to get dressed, essentially. You know, we don't want them to be challenged by using zippers or buttons or really tight clothes like leggings and things like that. So the looser something is, elastic bands are great. That's what we recommend first. And then one other tool that I brought is what we call a sock aid, which is this guy. So again, if somebody has a hip replacement, again, you can't do that bending motion. Or sometimes people will just come in with really bad chronic low back. This can be something that we use to just kind of help make it a little bit easier. And so this is going to allow people to put their socks on without having to bend over. So you're going to take the sock and you're going to thread it over the top and bottom. Just like...
That looks like that alone might be challenging
Yes.
for somebody who's already getting occupational therapy.
Yes. So because we have these tools, you have to really kind of think about who is going to benefit them from the most. So if I had somebody who had really poor like hand strength or their fingers weren't working very well, this is not something that I would recommend for them, because this is just going to become really frustrating for them and they're not going to be successful. And that's not our job. We want to promote success. We want to promote independence. So you really have to kind of know when it's appropriate to, one, use a piece of adaptive equipment, and two, make sure that it's a piece of equipment that's actually going to help them instead of really hinder them. Because what you don't want to do is keep showing them more and more things that they can't do. You don't want to set them up for failure. You want to, everybody wants to be successful.
It'll make them frustrated.
Exactly. Okay, so once you have this on there, you're going to take these ropes and you're going to flick it out in front of you.
Hold on,
down
get me
here on the floor.
Feet.
Perfect. I'll put it forward a little bit more. Maybe come back. Here we go. Okay, and we're just going to slide. Here, I'll go like this so you guys can see better. I'm just going to slide my foot in, and then I'm just going to pull up on the ropes and then just put my sock on. So, not maybe a big deal to all of you, but if you haven't been able to put your socks on in a long time and you live by yourself, these little successes mean a whole lot to somebody, and so that's what makes a smidge of my job a little bit rewarding. So,
Awesome.
yeah.
What other equipment that maybe you don't have today do you use?
So we use, you can actually find them in the grocery store. At CVS, we use like a long-handled sponge, so like the loofah or something on a stick, right? We'll encourage patients to use those.
To wash their bodies.
Yes, to wash their lower legs, again, because they can't bend over. A lot of times we'll recommend, so more of the common equipment that people may have seen are shower chairs, something that we call a bedside commode, where it's kind of like an apparatus that sits right next to the bed and it has a bucket in it, in case somebody can't walk very far, they can still feel like they're going to the bathroom. But we have things that can like slide onto their hands that has a little hole in it that if they don't have any like finger dexterity, we can stick like a spoon or a fork, so maybe they have more gross motor, so they can like stab a piece of food and bring it to their mouth. So they're really only having to use their arm, they're not having to use their hand.
Fingers.
Yeah. So we'll use that. Sometimes we have things that go around the plate to kind of keep their food on it. It's called a plate guard. So if they go to scoop and they're not successful, they have something that will kind of hit up against the plate to give them a steady surface to then scoop their food. Sometimes we have like weighted utensils for people who have Parkinson's, so they shake a lot when they go to do what we call like an essential movement. So if they're going to like pick up a cup, and you'll see them shake sometimes as they're bringing it to their mouth. Sometimes if you put weight to that cup or utensil or whatever, it will actually slow the tremor down so they can control it a little bit more. There's all kinds of things. Even stuff on the iPad can really help. Just having to kind of like pick a certain app. We call, if you're just going to use one finger at a time, we call that digit isolation. So if I want to work on my patient kind of moving their fingers a little bit more, let's say they've had a stroke and it's not working just right, I want them to work on being able to point. I might put, an iPad in front of them and say like, okay, open up the YouTube app, and I want to see them like be able to push hard enough to really be able to open the app. So there's all kinds of things out there.
The iPads are provided by the hospital?
Some of them are, yes. Now, a lot of the times patients come with their own because there's nothing to do in the hospital, unfortunately, and you can only watch so much television. So if they have their own, we'll use what they have because we want them to become successful with what they
their
have.
own tools.
Sometimes it can be a little bit challenging if, you know, you've done it this way in the hospital for so long, then you go home and you try to do it at home, you're like, whoa, this is a little different. That can also be very challenging in its own ways.
Have you had patients that have come into the hospital, left and gone home, and then had to return?
Yes, but if they return to us, it's because unfortunately something else has happened.
It's like a different injury.
Correct.
Okay.
Or they have had another stroke or something that they had got worse when they got home. So yes. I mean, that's something else that OTs can do as well. You know, I mentioned outpatient clinics and I mentioned other hospitals and things, but there's also home health. It's a very big thing in our profession, as well as with physical therapy, where there are therapists that go to the patient's home and they will give them therapy at home. Sometimes it's at home because, you know, they can't drive, so they can't go to the clinic, or it's not safe for them to drive or whatever, or the patient needs help kind of modifying their house, rearranging things to kind of, again, promote success for in their own environment. So therapists will come in and kind of help guide them of how to either rearrange, or if a patient has a very specific thing they want to work on, sometimes like getting in and out of a bathtub, sometimes it's easier to do it in your own environment than in a simulated one.
If you wanted to send a message to maybe students that might now be interested into occupational therapy, what message would you send them?
I would definitely say if we weren't in the middle of a pandemic and the opportunity presents itself to observe somebody, I think that's the biggest takeaway from this, because that's what happened to me. You know, I thought I was going to be doing something totally different in my career, and it wasn't until I watched somebody else do something that I was like, okay, I think this is maybe what I could do. I think being able to kind of see, or if you get the opportunity to have you know, maybe some hands-on experience with any of that type of stuff, I think that in itself will help you learn and might kind of guide you, and maybe you'll decide this is not what you want to do, you know, and that's okay too. But I think doing your research and really educating yourself and kind of finding out what opportunities are out there, instead of maybe just saying like, I'm going to be this, and then you get so far into your education and you're like, no, and then you have to start all over. You know, that's not what anybody wants to do, and you're so close to being done. So my biggest thing I would say is if you can go and observe, definitely go and observe. Even if you think you might want to be a physical therapist or a speech therapist, or you think maybe rehab in general is something you would like, but you don't know which one, go to all three. I think the more you can kind of absorb yourself and observe, and instead of getting, you know, ideas and suggestions from others, if you can go and actually see it and experience it yourself, that's going to be the best thing you can do.
Well, thank you so much for sharing.
You're welcome.
We appreciate having you here
course.
in class.